Hello and welcome to the FHT Virtual Conference 2022. My name is Sarah Catlow. I'm the Programme Area Lead of Sports Therapy and Rehabilitation at Plymouth Marjon University. My presentation today is looking at foot mechanics and its links to injury prevention within golf. The objectives of the session today is just to kind of give a brief overview of kind of feet and gait. Then we'll be looking at what the RS FootScanner can do and the kind of data it can collect and what a therapist can use that data for. We'll be looking at a real-life case study, so a 54-year-old golfer. We'll be looking at the data that he produces, and then we're looking at how we can treat and rehabilitate him, looking at injury prevention, as well as maximizing performance. We're going to have a look now about what is gait and just give a really brief overview. It's really important to understand kind of the simple aspects of gait when we come to looking at the data from the RS FootScanner, so we can utilize it effectively for injury prevention and to maximize performance. So the definition of gait in really simple terms is simply the pattern of how a person walks. Gait can be split into two phases. So we can have the swing phase, and that is when the foot is not in contact with the ground. And then we can have the stance phase, and that is when the foot is in contact with the ground. So the swing phase occurs when the foot begins to leave the ground and it ends with the heel strike of the same foot. The stance phase is composed of all the activities that occur when the foot is in contact with the ground. And that begins with the heel strike and finishes with the toe off on the same foot. The stance phase accounts for 60% of the gait cycle, and the swing phase is 40% of the gait cycle. The way the person moves his or her body through these two phases usually provides enough information to diagnose if there is a problem with gait. This is known as observational gait analysis, and I'm sure many of us do this within a clinical setting. Many parameters are considered during observational gait analysis. So we look at step length, stride length, speed, trunk rotation, arm swing. If a person's gait abnormality is more complex, you can further analyze gait using various modalities that go beyond observational gait analysis. And this is where the RS FootScanner comes into play. Now we're just going to look at kind of the definitions within the phases of gait. So we can have a little bit of knowledge and understanding for when we actually look at the whole gait cycle. And then use that knowledge to look at the data from the golfer and to make clear conclusions on kind of what treatment and rehabilitation we can give this individual. So we already mentioned the stance and the swing phase of gait. So that's how we simplified it at the start of the presentation. So the period of the gait cycle when the foot is in contact with the ground, that is the stance phase. And that makes up roughly 60% of the whole gait cycle. We have the swing phase, and this is the period of gait when the foot is not in contact with the ground, and that is roughly 40% of the gait cycle. We have stride. So this is the period from foot contact to the next contact on the same foot. Then we have the step. So that is the period from foot contact to the initial contact of the opposite foot. And again, gait cycle is the same definition as stride. We also have cadence, and this is the number of steps taken in a given time period. We won't be looking at this within our case study today, but it is quite an important aspect when we look at cadence and injury prevention with other types of patients. So now I'm going to look at kind of the breakdown of gait. So gait we can actually break down into 8 sections. So we've already mentioned we have stride, we have the stance, and we have the swing. Within the stance one, we have weight acceptance and single limb support. And within the swing, we have limb advancement, so how we move forward when we walk. As you can see at the bottom, there are 8 sections. So I'm going to explain these kind of 8 sections, very briefly, just so that you can have some form of understanding. So the first one is the stance phase. So this is initial contact, and this is where we normally start with the first phase of gait. It's easier to start at this point because the first ground contact is identified with ease. So the heel strike, so when we start walking, we'll put a heel down and is accurate 90% of the time. There may be some neurological or range of motion issues that can cause a foot to be flat-footed or a forefoot strike walking gait pattern. So that's the first thing that we look at, the heel strike and the move forward. The initial contact is part of weight acceptance, and this kind of absorbs the shock. We need to provide limb stability and preserve forward progression of the movement. So the posture of the hip, the knee, and the foot will determine the loading response pattern of the limb. And that's one thing that's really important with looking at gait and any problems with gait is the whole kinetic chain. So it's not just about the foot. So if the foot is placed incorrectly, that can have problems with the knee and the hip and the ankle. So normally in this phase, initial contact will take place on the heel, and that is setting up for what we know is the heel rocker, which is part of the loading response. So if we go on to the next phase, so this is the loading response. So after initial contact, the body weight starts to progress forward because obviously that's how we move. And it causes a rolling or rocking action at the heel. And this is known as the heel rocker. The heel rocker will help to cause flexion at the knee and plantar flexion at the ankle to bring the whole foot in contact with the ground. So in this phase, knee flexion is essential in order to absorb the shock of the ground reaction force. So ground reaction force is the force exerted by the ground as a counterforce to the force exerted on the ground from weight bearing. So this is Newton's third law of motion. So the third one is the mid stance. So this is the third phase of gait, and it is the first phase of single limb support. Now, the stance limb has total responsibility for supporting body weight, keeping a level pelvis and staying balanced. So this is when the opposite foot is lifted. So you can see here on the diagram. So walking forward and the other foot is starting to lift. And that leads us on to the fourth phase of gait. Again, we're still in a single limb support phase. And the purpose of this phase is to progress the body past the supporting foot. So the period starts with a heel rise on the stance limb and extends when the opposite limb makes initial contact. And the hip and knee continue to extend to allow kind of forward movement. The rocker in this phase is called the forefoot rocker. After the heel lifts off the ground, the weight on the stance limb will shift over the metatarsals heads, and with proper calf, ankle, and foot strength, cause a rocker at the front of the foot. And then that leads us into the fifth phase. So that's the swing phase, and this is the pre-swing. So this is the second period of double limb support, and the goal of this phase is to position the limb for swing. So the phase starts off with initial contact on the opposite limb and ends with the same side toe off. And this phase can be termed toe off or weight release. That leads us into the sixth phase, which is the initial swing. And this again is a period of single limb support. So the goal of this phase is the swing foot clearance for balance and the limb advancement to continue forward progression. Then we go into the seventh phase, which is the mid-swing phase. And this is another period of single limb support. This phase begins as the swing foot crosses the stance foot and ends as the tibia of the swing limb achieves a vertical position. So the goals of this phase is remain foot clearance and limb advancement. Then we go into the final phase of gait. And the goal of this phase is to complete limb advancement and prepare the limb for the next stance phase. So this phase begins just after the tibia is vertical and ends with the same foot touching the ground. And that is one step broken down into 8 phases. So we're going to look at normal walking requirements. What is required within a normal walking gait? So there are 4 major criteria essential to walking. So we've got the equilibrium, and that's the ability to assume an upright position and maintain balance while we're walking and going through the gait cycle. We have locomotion, and that is the ability to initiate and maintain rhythmic stepping through the gait cycle. We also have musculoskeletal integrity, so that's normal bone, joint, and muscle function. And we have neurological control. So when we perform the gait cycle, gait patterning, we must receive and send messages telling the body how and when to move. So let's look at gait pathology, things that could be wrong within gait. It's really important to understand these and know what we're looking for. So when we look at the RS FootScanner data, we can see, are people pulling their heel down too heavy? Are they actually missing putting their heel down and they're going straight to their toes? And why is that happening? So gait pathologies are deviations from normal gait patterns. So they result from pain. So if someone's in pain, they will avoid certain movement patterns, or they won't put a heel down or anything like that. So they will change their gait patterning if certain joints are in pain. With injury and surgery, we have ROM restrictions. So for example, if we have a restriction in dorsiflexion, that will then impact on gait. We might have weaknesses of certain muscle groups, and we might have balance deficits as well. So when we consider all normal components of stance and swing phase of a gait cycle or stride, so we need to look at those, know what is normal and what isn't normal, and what is causing it. We normally compare left and right sides when we're observing a person's gait pattern. And on the RS FootScanner, we will see right and left foot, both statically and dynamically. So looking at different types of gait. So we have a painful gait, and that's when certain individuals will avoid certain movements. So they might not put a heel down. Their knee might be slightly in flexion because they have a painful knee, and then that will have an impact on the gait cycle. We have the neuropathic gait, so that's also known as the high steppage gait, and that's caused by motor weakness of the nerves supplying the ankle dorsiflexion muscles, i.e. the tibialis anterior. During this kind of gait, there's a foot drop because there's a weakness of dorsiflexion. So the foot will drop and the toes will drag during the swing phase. And to prevent the toes from dragging on the floor, the hip and knee flexes excessively, and that will create a high stepping gait. We have the myopathic gait, also known as the waddling gait or the Trennenberg gait. And this is when the hip adductors are weak, so they're unable to contract and stabilize the pelvis during the stance phase. If someone is carrying an injury, their gait patterning will change. So if someone has a painful knee, normally they will hold it in flexion throughout the gait, and swelling reduces the tension on the knee joint capsule. So to compensate for knee flexion is avoided in that you have like an avoidance of heel strike and toe walking on the affected side. So we can see a difference between right and left as someone has pain within their knee. If we have a limited ligament instability, you'll see hyperextension. So the stride length will shorten and normal heel to toe motion will be lost. If anyone has a forefoot problem, patients will actually avoid plantar flexion and toe off. Or if we have problems with ankle or hind foot, patients will avoid the heel strike at initial contact, so therefore they will toe walk. If someone has a tight calf or tight gastrocnemius, we normally will see loss of heel contact and heel to toe motion, and then we'll see a slight exaggerated hip and knee flexion during the swing phase, and that is just in order to clear the toe. With forefoot problems, so a sprain or a fracture, they will actually reduce the load on forefoot by decreasing plantar flexion during the stance phase, and that will then increase the load to the heel. Leg length discrepancy, if we're observing them as a whole, we will see a shoulder dropping, and we'll actually see a compensatory pelvic drop as well. With a glute max problem, we'll see what we call a lurch gait. The glute max is a major hip extensor and a stabilizer of the hip joint, and basically it will throw the hip backwards. If we see weakness in ankle dorsiflexion, we actually hear a drop foot, so we'll hear a slap, and that's due to the eccentric control of dorsiflexion being decreased. If we have a gastric soleus weakness, we'll see a loss of ankle dorsiflexion control, and we'll see a shortening of the stride on the unaffected side. So within the RS scanner, when we look at the data, especially during the dynamic phase, we can compare right and left, and we can actually see the difference of timing on right and left from heel strike to toe off, and have a look. And then we have to work out, why is there that difference? What is going on? What else do I need to assess? And what else do I need to do? So before we go through the RS FootScanner and kind of the data we can collect from it, I'm going to introduce you to the case study that we're going to use today. So this is a real life individual that we collected the data from. So it's a 54-year-old male amateur golfer. He has a handicap index of 8.2 right now. He is right-handed. He normally plays golf 3 to 4 times a week, but due to work commitments, it's been limited over the last 6 months. He'd be retiring soon and he's going to make up for lost time. So he would like to play at least 5 or even more times a week. So he had an operation about 10 years ago in his lower back. So he's got a little bit of scar tissue around L4, L5, and he experiences some back pain from time to time. Overall, he's a fit and healthy 54-year-old. He walks the dogs for 2 hours a day. He did sit down for most of the day when he was working, so online meetings. His overall kind of goal that where he wants to get to is get his handicap index to 5 within the next 12 months. So we used the RS FootScanner on this individual. We looked at static and dynamic, and we looked at kind of gait cycle and see if there's any problems going on and whether we could maybe reduce injury or increase his performance by making very, very small corrections. The good thing is that you'll see in a minute about the RS FootScanner, it's really instant, it's very visual, and we can make very slight changes. So we might go, actually, we're going to tape this, or we're going to do this. And we can see those changes instantly on the screen with the RS FootScanner. So I kind of talked about gait, changes with gait with injury, plus I've introduced our case study of our golfer. Now I'm going to talk about the RS FootScanner and how we might utilize this data to improve our golfer's performance, look for possible injuries, and biomechanical issues with the feet. So just to kind of talk about feet in general. So foot morphology, the research within this area is really increasing, both from biomechanists, researchers, and footwear manufacturers as well. Normally feet are kind of split into 2 areas. So people that are flat-footed and people that maybe have a high arch foot. And normally we can see this by visual inspection of footprint shapes or from our objective assessment with our patient. Personal characteristics such as gender, body mass index, and age have all been shown to have a significant influence on adult foot morphology. The human foot shape also differs amongst ethnic groups and changes in the course of postnatal development. So it changes, foot morphology will change during pregnancy, and also it will develop through as a child grows. So that's why it's really important to look after children's feet when they are younger, up to when kind of they get older. So foot morphology is really important. So just to talk about the RS FootScanner. So this is a really simple machine to use. I might sound quite scary when I use words biomechanists, data, numbers, but it is actually really easy to use. I am a sports therapist, so I'm not a biomechanist, but I can use this piece of machinery. It gives me objective data about my patient, and I can make changes from the data that I see to either improve mechanical performance or to reduce injuries or kind of prevent injuries from happening. I can see certain areas. So Adidas actually used this machine to design some of their new trainers. And in one of the studies they produced, they concluded that 44% of sports injuries are actually due to incorrect sports shoes. So the RS FootScanner measures pressure distribution of the feet, and it can record up to 500 frames of data a second. And this allows kind of in-depth analysis of the pressure and force distributions and kind of link it into the biomechanics of the foot. So uses of the scanner. So it can look at foot and lower limb, kind of overuse injuries. It can look at mechanical performance, so biomechanics. So to enhancement to minimize injury and to maximize efficiency of the individual. What's so great about it is that you can use it statically and dynamically. So sometimes the foot position statically will be different to how we walk and how it changes as we put the weight through it and we go through the gait cycle. We can use shoes on or shoes off. And I'm not going to show this today, but from the machine, you can actually customize insoles and they can be made for those individuals as well. What's great about this piece of machinery is it gives very colorful pictures. You can see the changes. It gives very easy numbers for you to follow. And you can see change instantly. So for example, I might be working with someone with a foot complaint, and I might want to use sports tape on them or kinesiology tape on them to maybe reduce special pressure spots or to correct the way the foot is going during gait. What is great about this is I can measure them, then tape them, and then re-measure them and see if I've actually made a difference with that individual. So looking at the machine to start with, all it is a mat. So as you can see on the picture, it is just a mat. And it's connected to a computer program. To calibrate it, it is really, really simple. So all I do is get my individual, I put their weight in there and their shoe size, and I just get them to walk across it a few times, and that is all I do. And then the machine is then ready to go. So it doesn't take very long at all to calibrate it. It's very easy to transport as well. So I can bring it and analyze squads out in the field very, very quickly because it's not too complicated to set up. I can store the data and I can look at the data at a later date if I wish. And I can also compare the data. I'm not going to show this today, but I actually have data from myself pre-pregnancy, when I was pregnant and post-pregnancy. And you can actually see how my foot morphology had changed during those kind of 2 years. And now I have to make changes to my foot morphology to reduce injury. This is just an example of a scan of someone statically. I'm going to explain this in a little bit more detail later on in the presentation. But this is the kind of data we get. Obviously, the full screen isn't on there. So on the right-hand side, it will give you kind of how much pressure is going through the foot. So the redder the area, the more pressure there is. So looking at this individual just standing statically, we can tell there's quite a lot of pressure going through the fifth metatarsal or the base of the fifth metatarsal. And we can also see there's a lot of pressure or pressure starting to come through in the heel just from standing. And also only their first and second metatarsal is touching. What's happened to the rest of those toes? So we can look at this patient dynamically as well. And you'll see later on in the presentation that the patient statically shows this, but dynamically their foot kind of changes when we go through the cycle of gait. We can see here that they have normal arches, that those aren't too bad. And I can, if I wanted to make any changes with treatment of rehabilitation, I can then rescan them and have a look and see if I've made those adjustments to that patient. Now we're going to look at some of the RS FootScanner data and the case study. So we're going to look at static foot position. So just as the golfer is standing still on the scanner. So just to give you an overview, this is a 54-year-old male amateur golfer. They have a handicap index of 8.2. They're right-handed. They normally play golf 3 to 4 times a week, but due to work commitments, it's been limited over the last 6 months. They have actually now retired, and they're now playing nearly up to 5 times a week. So they had an operation 10 years ago, and they experienced some lower back pain from time to time from this. They're overall fit and healthy, and obviously their overall goal is to reduce the handicap index to 5 within the next 12 months. So the first thing when we work with any patient is, what do you think is important for this patient? What do we need to look at? What do you know about feet in golf? And what do you know about the mechanics of golf? There isn't enough time in this presentation to discuss everything about the mechanics of golf. I'm going to give you a few key pointers to keep in mind when we go through this data. But feet in golf are really important. We need that base, that equal base, especially when we're swinging the club as well, because there is a weight transfer from one foot to the other. So golf and injuries, many golfing related injuries, if we look at the research, are results as a result of poor mechanics or overuse. The most commonly injured area is actually the lower back. So 30% of injuries that we see with golfers, it's in the lower back. We can also see injuries within the elbow, wrist, hand, and shoulder. Now, foot injuries are also common in golf because of the extreme forces that the golfers will exert through the feet and how these forces are distributed during kind of their swing. So it's important to know that if you think about the golf rotation, so if we're driving the ball, they will have that rotation in lower back, but their foot position will change as well. So if we have something wrong with the foot mechanics, that can impact on the swing and obviously can cause injury as well. So this is an example, well, this is actually the golfers' data. So we measure them statically. And I've got two kind of slides looking at this. So what the RS FootScanner tells me. So it gives me a lovely picture of the feet statically. And it also tells me about distribution. So where is that pressure distributed? So if we look at left and right, so there's what? 5% difference between left and right. Normally one person is dominant on one side. So we expect to see a little bit more weight held on one side. So those figures don't really worry me too much. And then we can see the difference between front and rear. So again, it's about 8%. So that's not too bad. The body likes to be balanced. The body likes to be equal. And if we see major differences, the body is not balanced and we will see injuries taking place. But looking at these figures or looking at the scan, we can see there's a lot of pressure on the lateral aspect of the foot. Again, we can't use this as a diagnostic tool, so we can't say, oh, it means this. This can actually give us more information so we can look at in our objective assessment with our patient and ask more questions. So seeing pressure on the fifth metatarsal, that could be many, many different things. It could be arthritis. It could be a potential stress, a high risk of stress fractures. It could be they might have suffered a previous ankle sprain or have something wrong with the perineal muscles. So I know that this patient has not had any ankle sprains. There is slight numbness down that side of the leg due to being operated on, but it's only on one side, not on both sides. So I need to look at that and think, why are they putting so much pressure on that lateral aspect? The reason why front and rear are near enough balance is because there's pressure on the heel as well. What I should have done and what I didn't think of at the time was actually to get them to stand up and lift their heels off so they go up onto the foot and look at the pressure where those pressure kind of points appear on the foot as well. And that is something I will look at with the patient further on down their treatment and rehabilitation kind of plan. Also, I'm looking at the toes. So we've got the first and second metatarsals there. Where are the rest of the toes and kind of what are they doing as well? If we look at the right-hand side of the data, as I said before, it gives us what the pressure means. So it color coordinates it for us, so that's really nice. And it's measured in newtons per centimeter squared. So I can see how much pressure is going through those certain aspects. Also on the top right-hand side, there is like the old-fashioned, when we used to do the wet footprint thing many, many years ago, it shows you that in black and white. So again, it really highlights where those pressures kind of points are. So we can see that they're in the heel and the fifth metatarsal with that. So we've looked at kind of plantar pressure, so kind of static pressure from the golfer. Now we're going to look at center of pressure, so COP as it's abbreviated. So this is the single point of application of all the forces your feet are producing on the ground. It is the weighted average of where all your forces could be substituted by one equivalent force. It has been suggested by research that center of pressure provides a greater insight into dynamic foot function compared to measurements that are kind of confined to discrete regions such as peak pressure and maximal force. So center of pressure kind of is linked to foot structure, and it's more reliable and practical than plantar pressure. So the displacement of the center of pressure can provide insights into functional foot behavior and balance performance. So with the next set of data, we're going to look at center of pressure when the golfer is standing on their dominant foot, and looking at the data from there. We only keep them for 10 seconds. So we only take 10 seconds worth of measurements. You can adjust this on the foot scanner, but normally 10 seconds will give us the information that we require. But obviously we don't take them to fatigue with just 10 seconds on one foot. Also, we can look at center of pressure on dynamic gait. So when we're actually looking at a walking gait as well. So that is quite interesting. So we can get two sets of data from this. So this is just a screenshot, and I'll show you the video of a minute looking at center of pressure. So we can look at it at different axes and kind of distance traveled. So if you see kind of the white aspect in the front, that is how the foot moves while they're on one foot. Now, normally we have both feet on there, and the foot scanner will give a countdown from 5 to 0. And then when it hits 0, it will start recording. And that is when the athlete will then lift up whatever foot they require. So you do get a little bit of, the foot will readjust itself from going from 2 feet to 1 foot. And we're looking at how much that kind of white line moves, and seeing how stable the foot is. So this is an overall picture of where the pressure is going with the athlete. So if we look at the video from this, so as you can see here, they lift their foot up, and we're looking at the base of the foot. How is the foot stable during it? What happens during that movement? So as you can see, the foot does get a little bit unstable when they lift the foot up to start with, and there's not very much base there. So obviously, a high risk of injury. And then the athlete, the muscles will kick in, I suppose, and the athlete will kind of stabilize themselves. So if we look at it again, there we go. There's hardly anything there. A lot of pressure is going through certain aspects of the foot. But overall, that's not too bad. We're now going to look at the dynamic data from the golfer. But there's a few things to mention before we actually look at the data. So a lot of therapists will say pronation is really destructive or an injury risk factor. But during gait, you actually do need some degree of pronation in order to fully utilize the foot. Now, pronation will actually cause the foot to deform and absorb kinetic energy in each step. It's stated that the windlass mechanism returns as much as 17% of the energy kind of produced with each step. During human running gait, the forefoot will land first, as the impact will be too high for a heel strike and is more suited to a wider base of support. Now, the big toe must continue to control pronation to allow the correct loading on the plantar fascia, or as it's also known as the windlass mechanism, as the heel touches down on the ground. So we're going to talk a little bit more about the windlass mechanism and also some of the problems that we can see within foot dynamics. As you probably know, within a clinical setting, we can test for the windlass mechanism, and it's all about the big toe and the dorsiflexion that happens there. So the windlass mechanism of the foot is really important and an important structure for normal foot function. If you lift up any of the toes on a weight-bearing foot, especially the big toe, you will pull on the plantar fascia and the arch is lifted up, and that will activate the windlass mechanism. If we don't have a correct windlass mechanism, we can have problems with foot function or see injury. So I'm going to talk about some of the dysfunctions of the windlass mechanism. So some patients will have no windlass, and this can occur for one or two reasons. So the first metaphalangeal joint does not dorsiflex the required range of motion, or the plantar fascia is not there, as in a rupture. So what does this mean? It means there is nothing to support the foot through kind of the push-through phase of gait when the loads on the foot are high, and no supination of the foot when the tibia is trying to externally rotate. We have another dysfunction of the windlass mechanism. This is when high forces to get established. So basically, the big toe joint is really hard to move. then the heel is not going to be able to come off the ground unless a lot of effort is put into it. So can you imagine the load that then this puts through the tissues in the foot and the alteration to gait that occurs as the body tries to move that joint? We also have a delayed onset. So the assumption with gait is that as soon as the heel comes off the ground and the load goes on during propulsion, so going forward, the windlass should start straight away. Any delay in the windlass initiating is not going to leave the foot in a really good position to resist the loads that are going through them. So 0, 5, 10, or even 15 degrees of dorsiflexion before you start to see the arch come up as part of the windlass mechanism. So this means this is how far the heel has to come off the ground during gait before you have a stable foot from the windlass mechanism. So the windlass mechanism is really, really important. I think the key concept from that is it's all in your big toe. So do we have movement in your big toe? And obviously that is from when we can clinically test the windlass mechanism with our patients. So we're going to look at the dynamic movement now of the golfer. So this is an overall average of right or left foot. So looking at this, it looks quite normal. They look quite similar. Slight rotation going on. So we have the red line, which is the axis. And if you could just see the white line on there, that actually will measure the center of pressure. What's so great about this is it measures time for right and left, and you'll see that in the video in a minute. And we can see if there is a difference between right and left. As we know, the body likes to be balanced. And if the body isn't balanced, we will see or have the risk of injury. So we're going to look at the dynamic movement video now of the golfer. So if we look at this, so we're looking at both right and left. So this is an average that we can see. So this looks quite normal, quite average. The heel's gone down, midfoot's gone down. But if you start to see now, we can see a difference between right and left. So the big toe is coming in, and that's when we should start to see the rest of the foot lift. We can see that on the left foot. So that's really, really good. Right foot there's a massive delay on the right foot. We're still waiting. So the left foot's already up and moving, and now the right foot goes. So we're going to look at the video again in a minute, look at the difference between right and left, and look at the time delay on the right foot. But also we're going to look at the toes that are going on with the right foot. What happens to the big toe during the right foot movement? So let's just have another look at this video. We can watch again. So right and left foot, pretty average right now, and it's following the same protocol. So again, we look at the right foot, pressure goes into the big toe, same with the right foot. But we can see that it is just hanging there. So why is it taking so long for that big toe to work with? Again, we can't see on this video exactly why. Is there a problem with the first metatarsal joint or first metaphalangeal joint with this individual? And that is quite important if you think about the golf swing itself and the foot position in the golf swing and what the big toe and the stress going through the plantar fascia with that. Is there a high potential for injury? What happens if we can work and retest that big toe? So now looking at treatment, what can be done with this athlete? So at the minute, they don't have any major injuries, but they have the potential of being injured. My main question is there a problem with the right foot? I'm going to say yes. So looking at the difference between right and left, we can see a big difference with the right foot, especially during dynamic movement. So the windlass mechanism, also known as the movement of the medial longitudinal arch, is essential for shock absorption and kind of moving the forces through the foot. It explains how the foot can act as both as a rigid, level, and adapt with shock absorption during the stance phase of gait. I look at that and I think, well, actually, do I need to investigate the big toe and ankle dorsiflexion with this patient? Foot structures may be correlated with how well the windlass mechanism functions, and therefore could be correlated with how how the energy actually goes through the foot. For example, Lucas and al. in 2017 observed qualitatively that individuals with an impaired windlass mechanism, so a delayed or an absent mid-tarsal rise with passive and metatarsal phalangeal extension, have a greater arch mobility and lower arches compared to individuals with an intact windlass mechanism. Does this individual have a delayed windlass mechanism? And do we need to correct this to help performance and to reduce injury risk? Here are some really simple exercises that we could do with the patient to improve the windlass mechanism. So it is just working with the big toe and getting that movement in there and maybe reducing the stiffness and increasing ROM to help change the gait patterning. Excuse me, other things to do and other things to look at. I wouldn't just concentrate on the toe. So muscles that have the ability to influence height of medial longitudinal arch. So I'd look at the tibialis anterior, the tibialis posterior, the peroneals, and the gastrocnemius. If the calf's tight, I know with this individual patient, the gastroc and the soleus are very, very tight. Now, is there a difference between right and left, and is that causing the problem on the right foot? So I might look at releasing that gastrocnemius tightness, because obviously that can then have an impact on Achilles as well. So within other research, they made a note to emphasize that foot static and dynamic posture can be influenced by proximal neuromuscular control, such as glute med weakness, ankle dorsiflexion stiffness, Achilles kind of tightness, and tibialis posterior weaknesses. So again, I would look at this in more detail with my patient. So I know, again, working with this patient, they do have a glute weakness. The glutes don't fire. So again, that could be something that I could work on with this patient, increasing glute firing, and that might have an impact on gait. So why I encourage to keep toe extension close to the front of your mind, because obviously that is quite important with the dynamics of gait. You need to make sure you see the bigger picture as well and work with the other influences that can cause injuries. So my conclusion for this presentation is that correct foot alignment and motion are essential for injury prevention, as well as optimal performance. And sometimes just correcting feet alignment and working with that can correct things up the kinetic chain. So you've got to think of as a foot functions as it should be. So if it's working correctly, it would allow the leg joints and muscles to work correctly. But if we have even a slight deviation or restriction, that can actually become magnified as we walk, run, cut, and jump. So it can really influence within sport. If the foot is not functioning correctly, the body will eventually break down. That's quite a big statement. But it will all go up the kinetic chain. If my foot isn't going right during gait, especially during sport, when we magnify everything and more forces are going through that foot, we can see ankle, knee, hip, and even back injuries occurring. And I know from this golfer, they do experience lower back pain. And that could be many different reasons for this individual. But correcting the foot would that ease and make the movement within golf a little bit easier for them and reduce that risk of injury and pain. I'd just like to say a big thank you for listening to me in my presentation today. My contact details are on the screen here if you'd like to drop me an email and find out how well I've got on with this golfer and whether his handicap index has decreased to 5 and he's managed the whole golfing season without an injury. Thank you for listening.